Welcome, everybody. Thank you very much for joining today's meeting. We'll just bear with us for a moment as we sound in the room. Thank you very much. So welcome again, everybody. Very good to see everyone this afternoon for our board meeting in public. We're trying a new style of format this afternoon, which allows all members of the public and those joining remotely to be able to see us all and to know who's speaking. It also allows us to use the hands up function when we want to speak around the board table, which is most helpful. If this doesn't work, then we will revert to our previous style of being able to view the room in its totality. Welcome to everyone around the virtual and board table today. We have apologies from Rachel Porter, our Chief Nursing Officer, and we have Heidi Bedell, Deputy Chief Nursing Officer, here with us today. Apologies also and a thank you to Steve McManus, one of our partner members, who has now come to the end of his term on the board. Thank you to him for his service and his support. We have apologies also from Susan Parsonage. I need to remind us all that this is a meeting in public, not a public meeting. The event is being live streamed, and for those tuned in virtually, the tech is set up so that you can observe only. And to ensure that everyone can follow at home, we'll be asking all speakers to briefly state their name and role before each contribution. And as I say, our first time facilitating this way, and we are hopeful that it is a better experience for the journey. Let me start then with our declarations of interest. The current register of interest is attached for information, and I'd ask members of the board to declare if they have any new interests or any that are relevant to today's meeting. No? Thank you. The nature of our board with partner members means that there are inherent interests because of the organisations that they lead, and we accept those as reasonable and necessary for the functioning. I'm going to ask us then to look at our minutes from the board meeting held on the 13th of May, along with the action log and the matters arising. We have draft minutes from that meeting on the 13th for approval. Please could I ask members to offer any comment or approve as an accurate record of the meeting. Great. Thank you very much. These minutes presented always in a streamlined format, and the recordings of the board papers are uploaded for those wanting detail. The action log is being presented and has been updated with requests to close 3 of the actions under governance and partnership, performance and quality, board assurance committee updates. Are we content for those to be closed? Thank you very much, George. We have questions from the public. Where possible, presenters will answer questions during the relevant agenda items. We've received 4 questions which do not relate to today's agenda. Therefore, these will not be addressed during the meeting and will be responded to within 20 working days, as is our usual practice. For public and board awareness, these questions relate to performance and quality reporting published in May about autism and ADHD and statistics for adult referrals and waiting times. A question in relation to transferring of patients between providers and acute collaborative and whether the funding follows the patient. Third one about how the ICB will avoid duplication of work with public health and ensure the relevant teams work closely together. And a 4th question asking for the details of the provision for earwax removal in Reading by the NHS and what are their plans to improve this aspect of our health services in a community setting. Thank you to those who will respond with written answers, which will be published within 20 working days of today's meeting. I'm delighted then to turn to our resident story, and we have Heidi Bedell, our Deputy Chief Nurse, will introduce our resident story, and we have Andy Fitton, Head of Buckinghamshire CAMS and Eating Disorder Services from Oxford Health FT, joining us for this patient story. And this is Jacob's story. So a child's view of service delivery in the Buckinghamshire CAMS service. May I hand to you, Heidi?
Thank you, Chair. Afternoon, everybody. I'm Heidi Beddle and I'm the Deputy Chief Nurse Director of Quality. And as Chair has said, representing Rachel Corser, our Chief Nurse, this afternoon. I'll bring Andy in very shortly, but I think it's important just to recognise how vital it is that we improve the health and well-being of children and young people in our population. Nationally, it is understood that about 1 in 5 children and young people experience mental health issues. And this story really exemplifies not only the health services that are needed to support our children and young people, but that system-wide working with our partners in social care at the VSC sector and other providers. So if I can hand over to Andy, who is our service lead for CAMS, to share Jacob's story with us. Thanks, Andy.
Thanks, Heidi. Hello, everybody. My name's Andy Fitton. I'm the Head of Service for Buckinghamshire CAMS and Eating Disorder Services. Thank you for letting us come today to talk to you about what Jacob has experienced here in Buckinghamshire. Jacob is a child in care. He lives locally in a residential home that is provided by the local authority. That is his home and has been for a couple of years. He's about to turn 18, so he's going to obviously move on with his journey from that in time. But at the home,
Andy,
when he...
may I interrupt for a moment? We need to increase our volume in the room so that we can hear you better. So I'm just going to hold you for a moment and see if we are able to do that.
Is the TV at the house? Volume's up the full way. I can try the owl as a speaker. Yeah, through that. Did it come through the house? We could hear Grant earlier. Yeah.
Yes, absolutely. That's being said.
Maybe try again.
Shall I try again? Is that any better?
We don't think it's you, Andy. We think it's
okay.
Our side.
Sorry.
Oh no, not with us, Andy.
We'll try again. Yes, maybe that will.
Would you like me to try again? Is that any better?
Oh, yes.
Yes.
Yeah.
Yes, please, Andy. Thank you.
Shall I start again? Would that be helpful?
Sorry, can hear you well. Thanks.
Okay. So we're going to share with you Jacob's journey. Jacob is a child in care. He lives locally in Buckinghamshire in a residential home that's provided by the local authority. That's his home, and that's where he then met a colleague of ours called Hannah Hook, who is a clinical psychologist who works in part of the Buckinghamshire CAM called the ACE team, which stands for Adopted Care and Experiences, who have a very specific remit of working with a number of children in care in the local authority, whether they're foster cared or in a residential home. They're a bespoke provision, and they do work with the staff in the homes, training, supporting, consulting around the children and young people that they care for and look after. But they also do direct work with children and young people via an assessment into the therapy offer. And Hannah and Jacob's story, you're going to see it in a minute, is their conversation about his journey through the types of support he got from his network, the people that worked with him through some of his life. You'll see some good bits and some bad bits, ending up with a little bit more of a conversation about what Hannah did with him specifically and the therapy intervention that the NHS and the CAMS offered Jacob, and hopefully give you a clue of how it has helped him. So that's my introduction. I don't know if someone wants to reshare Jacob's story, then everyone can see Jacob's own words.
Thank you very much, Andy. We're just about to see that start. Thank you.
Wait a minute.
think we're just going to see if we can get audio.
Slightly split up, and I wanted to know the truth. It started.
Start from the beginning.
We start arriving at the new place. I left my children's home,
What should we call it?
the farm. I was really happy.
Where's the next stop on the road?
The next stop is I joined a new school, made some friends. Everything was all right until I started getting angry, and I wanted to figure out what was going on with my parents, why they split up, and I wanted to know the truth. It started getting to me, getting angry.
How did you cope with getting angry?
Oh yes, I started hanging around with the wrong crowd, the wrong friends, and led to me to start taking drugs. I became so dependent on drugs. It would help me, but the longer I was taking it, the more angrier I was getting. I started to lose myself, started losing everything, starting from my education. I started becoming physically and emotionally aggressive to people and wanted to control people. Started losing friends, losing family because of drugs, and eventually lost my placement and I got arrested. That's when everything started to change.
How did it change?
I became homeless, had nowhere to go until a friend gave me a place to stay and knew I needed to be somewhere. Him and his family helped me out massively.
What was life like for you then?
It was difficult, carried on spiraling down, eventually started getting angrier, started threatening weapons, threatening people's lives, getting a lot worse. And then I joined back into analytics. It helped me find who I am, who I was, and who I'm meant to be. Sarah helped me. She helped my anger. She made me feel loved in a way that I've never felt in a very long time. And then I moved into a children's home, and they believed I was ready enough to go to semi-independence. I had an apprenticeship, had skills. I'd become more resilient of myself.
Before we met, what were the main issues affecting you?
Anger, was losing myself again. Flashbacks from when I was a child affecting me, and it felt like I was starting to repeat my history again, and I wanted that to change.
And what's it been like?
It's
working
been,
together?
it's helped a lot. It's changed me, supported me, and removed a lot of that pressure that was on me from before.
What are some of the things that we've done together?
EMDR therapy.
People who don't know what that means, how would you describe it?
Shit.
Has it been hard at points?
Yeah, it's been difficult having to think about my childhood a lot. It was difficult to start rethinking it, and I've been pushing it away for so long. But from bringing it up has helped me in a way of accepting it, that it has happened.
Mhm.
And there's nothing I can do to change the past.
And what difference has that made to you?
It's made a huge difference. It's made me thought about it a lot less, made me a lot less angry I was before.
What are the most important things that you think people can do to help?
Listen, to know what they went through, to understand where they're coming from.
Where are you at in your life now? Where are you at on your road?
Right now I've got an apprenticeship going for me into something I really enjoy with horses. I've got a motorbike that I really wanted for a very long time. I've got a cat, I've got a girlfriend, I've got my independent skills have been improving massively, and my mental health has been going. It's been going really good recently.
Where does your road go in the future? Where do you want it to go?
I want to finish my apprenticeship, and I want to share my experience with other people who struggle, particularly in young schools, and to help kids who are going through a similar situation than me, to support them and advise them and talk to them, and to make them feel like they've been listened to.
Future. How do you feel?
Positive.
Thank you very much, Andy. Thank you very much to Jacob for sharing his story. Back to you, Andy.
Thank you, Chair. So not much to say except I did touch base with Hannah to find out how Jacob was, and he's still doing well, still living in the children's home, about to turn 18. So he's now planning for his next step of independence. So we're really excited. He said to Hannah that he's still managing himself really well. He's feeling like he's got his life where he wants it to be. There's been a couple of changes, but what's really positive is he's made another connection back to that organisation called Animal Antics. It really gives him a safe place. That comment that he feels loved there just always struck me. Every time I listen to it, it always makes me feel very, very warm and feeling like he's found somewhere that he belongs and it's his home. So I'm really pleased that we've been able to share it. We've shared it now 2 or 3 places, Jacob's story, and we keep checking in with Jacob that he's okay with that. And he's just really pleased to know that people are listening to his way, the way that he has experienced the support. As you can see, he's been through some tough times and he may still have tough times ahead, but I think he's learned some new skills and some new coping mechanisms with the support of Hannah and the ACE team. Thank you.
Thank you very much. And Heidi, I turn to you.
Thank you, Andy. Thank you. And once again, a huge thank you to Jacob for allowing us to share his story. It's really positive to hear that he continues to do well, and really mindful of that transition from child to adulthood and that phase of his life, and how important it is that health and social care continue to wrap around him and other children in his situation as they move into their next phase of life. Andy, thank you.
I open it up now to our board for comments and questions. Hey. No, you're fine.
Yeah, thank you for that, and a really lifting story and very moving. And okay, I guess one of the takeaways for me is, and it's not to take away from the story at all, but it's more of a challenge to us. How do we help Jacob earlier? How do we get there before he's had a problem to try and avoid some of those challenges? How do we move upstream a little bit? And the we is really important there, because it's not just we, it's we. It speaks very much to the whole point of integrated care, doesn't it? And I guess, you know, fundamentally from both the well-being of Jacob, but also from the sustainability of what we're trying to achieve, the challenge for us is to try and keep moving further upstream so that we can make that intervention more quickly. And that, you know, that from kind of an emotional point of view helps Jacob and others like Jacob to live a probably better kind of childhood and a more stable platform for adulthood. But as a system, it enables us to hopefully provide more sustainable services too. So it really is win-win. I know to some degree it's a very obvious statement, but it brings it into real sharp focus when you actually hear it, doesn't it?
Let me bring in Nick.
Andy, hi, it's Nick Broughton, Chief Executive of the ICB. Good to see you again. Can you just tell us a little bit about Animal Antics, what that involves?
I don't know a huge amount about it. The little I learned on the back of Jacob's story is it's a voluntary sector organisation based in the county that effectively creates a therapeutic environment to work with animals. And it obviously really speaks to some young people's experience of how they can feel accepted and feel like they're part of something. So I believe he's back there now, that they have a sort of an open access referral that people who feel that their children, young people could benefit from that type of experience, spend some time there. So that's as much as I know, Nick.
Okay, thanks, Andy.
Just picking up on Aidan's point about how we can look at those elements that we can do earlier and sooner in terms of Jacob's journey. Heidi, did you want to?
Thanks, Chair. This probably relates to an item that I was going to highlight in the Chief Executive's report, but I'll touch on it now. We really welcome the proposed Children's, Families and Schools Wellbeing Bill, and that will enable us to pick up the priority work that we need to do as part of Families First, which, as I said, is referenced in Nick's report. We've been working in collaboration with local authorities around the Families First piece, and I think that is our opportunity, Aidan, to go upstream, as you've mentioned, and support children at a much earlier phase in their life with mental health and social health issues.
Thank you. Thank you again, Andy and Heidi. And please, Andy, convey our thanks to Jacob. We are so pleased to hear how much he has changed his life and how things are now. And this is very inspiring for us. So thank you to him for sharing that with us.
Thank you. Of course, I'll pass that on.
I'm going to move us now to our Chief Executive and Director's report. So over to Nick Broughton, our Chief Executive. Thank you, Nick.
Brilliant. That's it. Good afternoon, everyone. I will take the reports as read, but I just want to say a few words before I hand over to members of the executive team to highlight any particular issues from their sections of the report. So the report really highlights there's a lot going on nationally, regionally and locally. Nationally, obviously, we're aware that the long-term plan, the 10-year plan, was published last Thursday. Clearly a very important moment in the history of the National Health Service. We are digesting the content of the report. We're very pleased and focuses so much on neighbourhood health, creating neighbourhood health centres, etc. And with that in mind, I'm pleased that our own neighbourhood health programme features on the agenda of today's report. Regionally, governance has been strengthened, not least to deliver the priorities for the South East region this year. You'll see this transition group now up and running. I sit on that wearing my mental health hat as the executive sponsor for the region's mental health programme. There's a lot going on within the organisation and across our system. Obviously, we have the transition programme, which I've referenced, and work is ongoing in relation to creating Thames Valley ICB. The proposal to do this has received positive feedback from the South East region, and as you see, we've established internal groups to drive forward work. We received our annual assessment from the South East region a few weeks ago, and this followed a meeting with the regional director and her team on the 7th of May. The assessment highlighted that the ICB has made some significant progress. However, continues to face some significant challenges, which I think we will all accept and indeed agree with. The assessment placed us on segment 3 of the oversight framework. However, it's important to highlight that since we received the letter, the oversight framework has changed. The new oversight framework and ICBs are not subject to segmentation this year, reflecting the scale of change that we're going through with the integration of ICBs across England. I'd also like to take this moment to put on record my thanks to Rachel Corser, our chief nurse. Rachel can't be here today, and we're grateful to Heidi deputising. Rachel will sadly be leaving the ICB next month to join Bart's NHS Trust as their new chief nursing officer. I'm sure we all wish her well in a new role, and we are all very grateful to her for everything she's done during her time with the ICB. She joined the organisation back in September 22. I think it's our longest serving, or one of our 2 longest serving executive directors. It's fair to say that she has been through a lot, including working with multiple chief executives, and I am incredibly grateful for the support she's provided me and her ongoing professionalism, and I think a remarkable commitment to nursing in the midwifery. I'm very pleased to report that as part of the work in train to create the new Thames Valley system. We have appointed Sarah Bellas, the Frimley ICB chief nurse, to be the joint chief nursing officer for both systems, and Sarah will take up that role following Rachel's departure. And already the two nursing directorates are working very closely. Indeed, their senior leadership teams met, I think it was on Friday last week, to talk through transition arrangements, etc. Before I hand over to Sandra, our chief people officer, just two other things I wanted to flag. Firstly, we had our first joint ICB MPs meeting last Friday. Really pleased that 10 of our local MPs were able to attend, and 5 others were able to send members of their personal officers to join the meeting. The meeting focused on ADHD services, the 10-year plan for health, the ICB transition, and primary care matters, particularly primary care estate issues. And then finally from me, we received, as we always do at this time of year, the annual reports from our local health watches. Really grateful to those organisations for their continued advocacy in relation to people who use healthcare services across our system. And obviously we are concerned regarding the proposal to abolish health watches as set out in the 10-year plan. And clearly moving forward, we as an organisation need to think about how we can fill the void that we left and ensure that there is a very strong patient voice across our system, and one that helps to influence any decisions that we make as a commissioning organisation. That's it from me. Very happy to take questions in due course, but I'll now hand over to Sandra.
Thank you. So Sandra Bond, Chief People Officer for the ICB. So my update provides information regarding both the system, workforce plans, and where we're up to with those, and the change process that's running through the ICB. So what we've got in those in our report here shows a month 1 position, and we're obviously now able to share month 2 figures. So just to update on where we're at with regard to what's shared there, there's been a slight deterioration in against workforce plan delivery from a full-time equivalent perspective. So people in post, which means that we're now 1.6 below plan. However, financially, we are outside of our pay costs, so there will be more coming through the finance report. Each of our trusts, most of our trusts, not all of them, are running what we call mutually agreed resignation schemes to offer leaving processes for staff that wish to leave with some form of compensation to help reduce some of their full-time costs. So that's what's going on in our system space. Obviously, we keep a close watch on that as we go through the year. With regard to internally, we have a focus really on meeting the new ICB model, blueprint model. So that change process that we have to embed is with regard to that. We're doing that in partnership with Frimley and with other ICBs, learning and how we do the process together, sharing resources where we can, expertise, and aligning our approach. So it's really just preparing for that change process, supporting the organisational design part of that, and then ensuring we are regularly connecting with staff to help us co-design things and our trade union colleagues. Final thing to say is we are awaiting a national voluntary redundancy scheme, which has not yet been issued. And we went to our remuneration committee recently to prepare for something called a mutually agreed resignation scheme, which we're waiting to see whether we get approval for that so that we can then go to NHS England and then take stock at that point. If the voluntary redundancy scheme is out there nationally, we might not offer that to staff because the voluntary redundancy scheme is more favourable for them. But we might proceed with that at that point. So it's just about having that as an option if the voluntary redundancy scheme is there nationally, so that staff who wish to leave early in the organisational change process are able to do that.
Thanks, Audrey. I should now pass to Ben to go into relation to the Chief Medical Officer.
Thanks. Just a few quick highlights. Our primary care team is currently working on a policy improvement initiative called Project 100, which is supporting 100 practices across our region. It's across the whole South East region. 100 that are showing metrics that are associated with their performance in areas like access and quality. 14 of those are located in Auburn area. In many cases, we were already aware of issues and working with practices for those, and an improvement plan has been together with the regions part of that program work. So we'll continue to monitor that and check that we improve those things. We're anticipating this will also reduce the variation that we see sometimes in access. We'll obviously keep the board updated on that. In positive news, the government's announced the practices which will receive funding from the Primary Care Utilisation Fund. 21 of those practices identified, which are going to get 2.8 million between them to this primarily things like the consulting industry, so it's about actual space to enable appointments to be provided, and we're anticipating that should provide about 200,000 a year in that capacity. Quite significant there. The health inequalities, the work programme funding is now being distributed to the 3 places. Health colleagues very much involved in that. We've done recently some targeted screening work for a population of asylum seekers, and a bit of to identify illnesses such as latent TB and hepatitis and so on. So we wanted to make sure that they have access to treatment as early as possible. And we're currently working on the screening plan for other locations across as well. And then finally, just a bit of an update on long-term health conditions, the ongoing work, a range of diseases, as they're called, the cardiovascular disease, early onset type 2 diabetes, and heart failure. Just a quick point on back to the stroke. So this last one is a really important intervention reducing long-term disability for people who have a stroke. I'm very pleased that our trusted board have achieved 10.6% recovery rates, which is actually the national guidance is about 10% of patients benefit from this. So stroke, so we're actually at that level, we're exceeding it, which actually puts us at the top end of the national agreements for this apparently. So that's really good work to prevent long-term disability patients.
Thank you, Ben. Heidi.
Thank you, Nick. I referenced earlier the Families First work, so delighted that we're developing our early thinking around that. Really positive to see that we've had a great start to the spring COVID campaign, and I believe we were second in the region with uptake, which was excellent. And then 2 other things quickly to note. There's quite an extensive summary in the report, but to touch on the growing national concern around child exploitation. This has been highlighted in the National Audit Office report, and our safeguarding teams continue to work closely with partners to ensure that we are putting all the right safeguards in place in our health and social care services to support survivors, but not only when it's a crisis. And then lastly, it was announced by Secretary of State for Health and Social Care on the 23rd of June that there will be a national maternity review. There are 2 parts to this review. The first being that up to 10 trusts in the country will have a urgent and very sort of forensic review, and then there'll be a wider systemic review of maternity. There are no further details at the moment about trusts that will be in that up to 10, and a task force has been set up, so we await further clarity.
Thank you, Heidi. And next, Matthew, our Chief Delivery Officer.
So I should pull out a couple of points from the report. Obviously, we'll cover areas a bit later in the agenda. So just to note, since our last board meeting, the Urgent Emergency Care Plan for 25-26 has been issued by NHS England, and we also are expecting in the next few weeks the winter letter. It's also got additional guidance on. So this report really highlights where we need to focus and work together during the winter period. It tends to bring out the key metrics that we're going to be monitored on during winter, so there's no great surprises there. So they are focusing on areas such as handover times, aim performance, vaccination rates, and so they're the areas that we will really have to focus on as we go into the winter months. All our local systems are developing winter plans. They tend to be a balance between a bit of a service focus on where we're expanding services or working together to put on additional capacity over the winter, but probably more of a focus on our operational response. So that's from an ICB perspective. Most of our winter plan will be how we are managing our day-to-day operational response. So discussions around our resilience status on a day-to-day basis, how we intervene, how we escalate and brief, and how we work with NHS England to challenges. So just wanted to note that, and I'm happy to work with you on if those plans have been reduced and what's appropriate to bring back to a future meeting in September. And then the only other point to highlight really is the issuing of the Part 1 report of the Independent ADHD Task Force. Really relevant because I think board members are aware of some of the local challenges we've got around our ADHD services, both for children and adults. And I think some key points here. What the most powerful, I think, is the clear acknowledgement that the specialist single diagnosis model not only not sustainable, but also is an evidence-based, evidence-informed model. Focus on early intervention, I think, which we'd all expect, all of the neurodivergent services, and a need to digitally transform the service and improve the data and reporting. I think that's particularly relevant given some of our SEND challenges across the patch, but also, all those I'm sure we're aware of some of the national coverage of some of the SEND challenges and some of the government debates around how we can mix with that as a country. So that's what I wanted to
Thanks, Matthew. We can take the Chief Strategy, Digital and Transformation Officer's report to read, which brings on to the Chief Finance Officer's report. Alison.
If all right, I will cover it under item 9 when I do the
Happy to take questions.
Thank you. Thanks to all of the chief officers for those updates. Comments and questions from board members?
It's for Ben, since the I'm Ned. Just thinking about the health and equality funding that's been allocated now, 3.6 million. It's not much, is it? When you think about the job we need to do. So I think just some assurance about how we can best use that small amount of money to put us in a good position then for what needs to be done. We cannot deliver health and equality improvement with that small amount of funding.
I mean, you're absolutely right that across the whole amount of spend to health equalities and prevention needs to be, much larger chunk of it, and that's very much set up in the 10-year plan. These are specific programs, I think, targeting things at place level, what could be worked out public health and local authority place partners. So, for example, on Berkshire West, there's a community outreach one focusing on picking up cases of cardiovascular disease because that was identified as a local need. But you're absolutely right, it's a sort of variation really of the scheme of spending. So that's how we sort of approached it. But I think going forwards, and we talk about that when we come to the neighbourhood item, that there needs to be a whole sort of programme around thinking about how we invest in this area and shift. And the Matthew Margaret's question for the place where it's been.
Yeah, I suppose I can add something to that. So Dan mentioned direct place in communities. So part of the benefit of having that small amount of money at places has been we've been able to leverage much wider funding as well. So the funding that's with local authority, funding that the voluntary community sector bring in, and the funding of things like the Better Care Fund as well. So really what we're looking at now is, like Ben said, it's very local and it's building quite a lot of what we're talking about, the foundational stuff that we'll talk about those of the neighbourhoods, so that communities that social capital within the communities, particularly those communities that experience the most communities. So there is a pooling of that resource that means it can go a little bit further out and sometimes faster, and we've been able to prove concepts of simple stuff. So community health and wellbeing workers that were mentioned in the 10-year plan, the growth funds and those in parts and we're doing it in bucket as well. So it's really good work that it can do. But like you say, there's a need to go much further across all of it.
Thank you. I'd like also to note now our board assurance framework and risks and mitigations. Nick, did you want to add anything to your?
No, just again, just take more spread in relation to that, and the cover sheet highlights the updates in relation to the relevant risks.
Thanks, Chair. Aidan Gray, Ned. I'm not sure I'm going to appear on screen. No, I want to miss it. Just more of a general comment, really. It's really gratifying to see so much activity in the midst of what is an incredibly difficult time for the organisation on a personal level. And Nick, I just thought it was maybe an opportunity for you by your weekly message to convey on behalf of the board our thanks to the staff just for the resilience that they're demonstrating. The sheer bandwidth of work that's going on is incredible. It would be incredible anyway to see some more given the content. So,
well, David, thank you for that. And I think you're right. The report highlights just quite how much is going on. And business as usual, if I can use that term, involves a huge amount. And on top of that, obviously, we have the transition programme and now the 10-year plan, how we implement that. It's opportune timing for you to say those kind words. Please have an all staff briefing tomorrow at 9:30. You're very welcome to join it. And I certainly will relay your thanks to the colleagues. And what's great about all staff briefings is that the vast majority of the workforce joins us. So we should have about 300 or so colleagues online tomorrow morning. And I certainly say thank you to them on behalf of them.
Thank you very much. Well said, Aidan. We'll move now to our annual report and accounts for the 2024-25 year, and over to Hannah Iqbal, our Chief Strategy, Digital and Transformation Officer, and Alistair Groom, our Chief Financial Officer.
Thank you, Priya. And maybe sticking with Aidan's point there, a big thank you to governance, finance and communications colleagues. This time of year is obviously very busy in terms of different submissions, and as the paper also outlines, the various governance toolkits that colleagues have to marshal and make sure we've got them all right. So excellent work from the team. I'll hand over to Sarah, who's led on the annual report, and then Alistair on the annual accounts. But suffice to say, as you'll see from the papers, we submitted on time and everything was in order. And it's really good and important actually this year, I think, just to mark the year that's been, particularly given the transition we're about to go into, and recognise all the work that the ICB has delivered at the core. Thank you, Sarah.
Thanks, Hannah. So I'm Sarah Adair, Associate Director of Communications and Engagement. So as Hannah said, I'm very pleased to confirm that we submitted the annual report and accounts for the past year to NHS England 20th of June, which was in line with our national requirements. The submission included the full annual report, which covers performance, governance and strategic delivery, the annual governance statement, remuneration report and supporting declarations that we have to give to NHS England. I think Alistair may go into a bit more detail about the annual accounts. But key points to note for the report is that the ICB delivered a financial balance at the end of the year with a 9,000 surplus. We received a positive head of internal audit. The report reflects a year of change. So as Heather alluded and colleagues around the table, we were implementing our new operating model, but the report does highlight progress across lots of key areas, including planned care, urgent and emergency care, digital transformation, health inequalities, and population health management. I'll leave it there.
Thank you, Sarah. Alistair Groom, Chief Finance Officer. I think you've all stolen my thunder. I'd equally like to thank the team. It was certainly not a certain fact that at this point in time we were going to hit break even, and we would have clean audit opinion, of course. But it's a credit to the organisation and everything it's delivered over the last year that we have delivered break even as a result of the year, and I would equally like to thank the team for all the work, both in finance and across the wider organisation, in actually controlling that expenditure and delivering it to plan. And it's great that we've got a clean audit opinion and a relatively straightforward audit close process. So nothing more for that.
Thank you very much. So very pleased to see that all of that has been submitted and is in order. Any comments or questions? Thank you. So that takes us nicely into this year. How are we doing? We're going to start with our finance month 2 and then performance and budget reports. So back to you, Alistair.
Thank you, Chair. So, Alistair, Chief Finance Officer. We're early in the year. It says month 1 on my agenda, but we're actually talking about month 2. We're on plan on month 2, but there are the plan is challenging. There was quite a lot of work at the plan closed in preparing cost improvement plans to deliver break-even across the system, which we're on track to do. The cost improvement plans at month 2 are showing that there's still certain elements of SIPs that need to be identified, and some that are slightly behind, but we are working to recover that in the coming months. In addition, at this point of the year, we're also putting all of those financial plans into contract. We're progressing well, and I think we're now at the point where all in-system contracts, we have a principal agreement. We have some challenges with a few out-of-system contracts, and some more work to be done working with the independent sector, and getting in place indicative activity plans that are required by the new contract management arrangements. 3 of the acute organisations show challenges in their cash balances during the year, and in particular 2 of them in the short term over the summer, maybe early autumn, and we're working with them to look at mechanisms to support them during that process. The final point I'd like to flag, which is in the report, is all ICBs up and down the country and NHS England are implementing a new accounting system on the 1st of October, and this is IFSE 2, and there are some risks around that which have been escalated to NHS England. So I think that's all I wanted to say. I'm happy to take any questions beforehand and put Matthew on.
Yes, should we have all of them in the round and then we'll question?
Right, I'm Matthew Tate, Chief Delivery Officer. So just a few points, and then I'll pass on to Heidi and Ben about any graphics there area. First of all, I think we spoke at the last board about the refresh of this report for the new operating year. We haven't made as much progress as we hoped in terms of the refresh as a result of some interruption in our business intelligence services during the course of the last couple of months, and therefore we haven't updated all of the reporting lines for new operational targets. But I'll give a bit of context, Chair, as I give my slides around that. We hope to have that it's all. So on urgent and emergency care, I think it's important to state that the oversight and the performance management of these is really against the plans that each of our trusts submitted and we signed off as part of the planning round. So the agreed trajectories and we monitor against them, and that's how the national tiering and oversight framework is focused as well. So on urgent and emergency care, generally we're on plan across the system. The challenged organisation at this time is Royal Berkshire in terms of delivering against the expected national target, and they have reached out for additional support from the regional team and been a clinical review of their operating model. We're hoping to see the final job shortly. On elective care, we continue to see improvement in long waiters, but just to note that the real target this year is moving back to a percentage target for referral to treatment times. And broadly speaking, Oxford and RBFT are in line with their targets. Buckinghamshire Trusts are behind in terms of their performance against that target. Most of that is a technical issue. They've actually identified a number of triage services that are not submission. So nevertheless, we do expect that recovery for us to demonstrate how they're going to get back on track. It's also important to note that Royal Berkshire Hospital did submit a non-compliant plan against the national expectation, and there is a series of reasons for the trust to understand that they could do better than to even the national system on RTT going into this year. We remain a very challenged system on cancer performance, and particularly the 62-day weight target. And I think, as I reported at the last board, we moved into tiering, which is a national framework for support around recovery across the system. We've had 3 sessions with the regional team and the 3 trusts to focus on the cancer improvement trajectories, with particular focus on the tumour pathways of gynecology, lower GI and urology. We've also agreed distribution of additional funding for the Thames Valley Cancer Alliance of over £1 million, and we've now received confirmation of £600,000 from the national team as part of the tiers. It's still early days, but we have seen some improvement in the very latest numbers around RBFT and Buckinghamshire Healthcare Trust. And whilst Oxford had a very poor April, you'll see some of the numbers presented today, we have seen some signs of recovery there. So I wouldn't underestimate the challenge that our trusts are facing around recovery, but we've got an investment and improvement plans that we're developing trusts. Briefly mentioning under L&D and autism, there was a range of questions, I think, which the Chair quite rightly said we'll answer in detail offline, but you will note CYP weights continue to be really challenged for autism and ADHD assessments. I would just say for adults, we do have some of that data. It's not as robust as we'd like in some areas, but we do have a waiting list around 5,000 across board for adults, and some of our services are presently paused due to demand. We have medium wait time, lost from train of thought. We have average 87 challenge to our services then. They were just the points I wanted to pull out. Happy to take questions, but Heidi, is there anything you wanted to highlight from the report at this stage?
Thanks, Matthew. I think just 3 things that I'd like to highlight. Firstly, the CQC inspection of forensic services at Oxford Health. The report has been received and they were rated overall as good, with all 5 domains rated as good. Secondly, to mention that we are starting to see an emergence in safe surgery, safe invasive procedure, never events again, and that has typically been the most frequently occurring never event over the last 2 years. That is not out of line with the national picture, but we are working with our providers, our acute providers, through an improvement collaborative to see what can we learn from those never event investigations and what could we perhaps do a bit more system-wide to reduce the incidence of those events. And then lastly, which I find really encouraging as we shift from sickness to prevention, is the maternity data around smoking and the success of the smoking cessation targeted work, and also the support of increasing breastfeeding rates. And these really are crucial to children starting well and getting that best start in life. So we're better than national average in a sustained manner, and that's really encouraging. Thank you.
Just a couple of things, because I've already mentioned the project one, so that's already covered that one. Just very briefly to mention, there's also an added risk around prescribing. Just explain that this relates to prescribing items such as wound dressings, stoma, care products, and catheters. Working with the local medical committee to change how those items are prescribed in future, so that they'll be prescribed through a central system rather than nursing services having to go to GPs to get individual prescriptions, which is quite a big workload for practices, and whether practices were then already adding value to that process. So we're trying to streamline that, and that will actually likely realise some opportunities to do it cost effectively as well. So that's great.
Thank you. Thank you very much. And so if we can bring in Sid. Thank you.
Thank you for the update report. Alistair, I wonder if I could just ask for a bit of clarification, but for me, remind me of the SIPs, the cost improvement plans. Do we have a bigger percentage not yet identified, or actually does our bigger percentage lie in identified SIPs? We just they're just coming on stream. So it's the unidentified SIPs which are the challenge of worry. They're the ones that we don't obviously are. So is there a bigger percentage of those?
The unidentified SIPs are a very small, a small portion of the total. I want to say 5%. NHS England was pushing to get 100% of all SIPs identified by the end of June. Most providers, I think all providers in the system, did identify all SIPs. The ICB hasn't quite identified all SIPs. NHS England will now move to the next level of maturity, which is fully developed. And so they're saying they're developing up a requirement that by, I think, the end of September, we need to have everything fully developed. But in terms of the overall scale, we're quite well identified, but there is still an element of risk, which is set the £5 million in that.
Tim?
Thanks, Priya. Tim Nolan, Non-Exec Director. There's a question from Matthew and perhaps Ben as well around the cancer performance. Just appreciate a lot of works in hand, and obviously we've got a relatively new leader of the Cancer Alliance, which is good. Are we in a position where the 3 acute trusts are all on board with the best practice pathways? I think there's 5 or 6 of them nationally, I think. Are all of the trusts adopting all of those best practice pathways?
Yes, they're all working towards it. I think this is part of the role of the Cancer Alliance, that actually at pathway level, they go in and support the trusts, check those pathways are working and make recommendations for improvement. So I think the challenge is, whilst they're all working towards them, how effective is their implementation? We need to really make them a best practice. So I would summarise.
And is there a sense that we're getting closer towards that the implementation is improving across the board? Are there any, I suppose really what I'm getting at, have we got any real sort of tough nuts that we're struggling collectively to crack? And if so, how can the ICB and the Alliance help in any way?
So I think it's a mixed picture. I think from the interactions I've had, there's a clear view that actually a lot of this is about how we manage the pathway. So whilst there are demand factors which we need to acknowledge in areas that, such as urology and skin, where the demand profile has increased, I think the transformation work that's happening within the trust, it's felt to be where we deliver sustained improvements. So I think that we're making good progress, but I think there's quite a lot to do. So I know we've discussed offline how we get the right level of the right assurance committee, and I'm happy to continue those discussions.
Thanks, Matt.
George.
So George Gabriel, partner for Private Medical Services. I'm just going to stick with the cancer numbers a little bit, but the change in BHT is quite the start of quite a month-on-month 10% increase. Do you have any insights into what that is? Is it a positive trend? Is it a reporting issue? Obviously, if it's a genuine improvement at that level, there's things to be learning.
Yeah, so without going into the detail, because I may struggle on the club, so I think what we're seeing in BHT is some unexpected demand profiling, and the response to that has been additional capacity. So they've had some gaps in staffing, and they've put on additional capacity to help recover the position. So I thought there's still a question mark about sustainability of the improvement, but they've definitely responded in terms of the demand, some of the staffing shortages they're based on pathways, particularly dermatology, in one challenge area.
That's really helpful, and be good to see how that develops, and what, as you say, what the lessons are in terms of how we can support implementation. Good. I'm going to move us now to our next agenda item, which is the Nottinghamshire Independent Homicide Review and the learning from that. And I'm going to hand back to Matthew Tate. Thank you very much.
Thank you, Chair. So Matthew Tate, Chief Delivery Officer again. So it's a really important report for today. I'm glad to be joined by Nikki Cartwright, who is the Director of Performance Delivery for Mental Health ID and Autism. So this report gives the board an update following the tragic events in Nottingham in June 2023, which resulted in a series of independent investigations via the Independent Mental Health Homicide process, and also builds on two Care Quality Commission special reports published in March and August 2020. But the focus of those was the learnings from the Trust, and also some key themes for broader mental health services that we should be aware of. And the Trust, two local trusts, have undertaken a self-assessment against that set of recommendations and areas for improvement, and they've taken those through their public boards to give assurance to the board about the position and some of the development developmental work required across the two organisations to ensure that services are effective and identify those members of the population at greatest risk. I think the work's been complete. It's gone through the local boards. There is a national commitment to take it to our ICB boards so that board members can be fully aware of it. We have oversight mechanisms in place, so both trusts have clear reporting mechanisms against it, and we will follow up as ICB both with the mental health survivor collaborative work streams and through our monthly bilateral trusts. One of the issues on this has been whether there is funding associated to support it. So you'll see from the report that a lot of the areas are for improvement within the organisation and do not require funding. There was a discussion about national funding and around support this. That has not at this point been confirmed. So we do need to acknowledge that there may be some challenges in terms of service development if additional funding is not. We'll get a sense from reports and trusts that they're taking it very seriously and very clear work to address. So that's all I was going to say by way of introduction, but I did want to give Nikki the opportunity to give a bit more context from her leadership perspective. Nikki, over to you.
Thanks, Matthew, and thank you for the introduction. So I think what you'll see if you turn to the section 3 of the paper, which is where we have our responses from Berkshire Healthcare Foundation Trust and Oxfordshire Healthcare Foundation Trust, that they have different areas of focus. There is some overlap, but their areas for development are very clearly set out. We know what their responses are. As Matthew said, we are looking, we've got the oversight and assurance around the delivery of those changes. We may know in June, well, June's gone now, but we may know shortly whether there is any further funding, because teams across the country were asked to identify what that would be, and there was a promise that they would come back to us during the summer period. My guess is that's probably a little bit delayed with the 10-year plan now. But I think it's just as Matthew said, it's a really important piece of work. These are the most people who suffer the greatest health inequalities within our mental health services, and it's important that we've got the sort of systems and processes in place to ensure that we keep not only them safe, but that we keep members of the public safe as well. So very happy to take any questions.
Thank you very much, Nikki, and for the reporting and for the clarity of the learning and the implementation. Comments and questions, Sandra.
Let's stand up just to so some of our chief people, obviously. Thanks, Nikki and Matthew. When it talks about the training and support that will be there for staff, have we looked broader than just the mental health trust? So that looks broadly at anybody that would need to be educated sufficiently in this space to support individuals. That looks broader, or is this report just about what's going on directly within the mental health trust?
It is just about what's happening in mental health trusts. And I think because the people that we are talking about and focusing on are the people who are probably, if you think of a pathway in a spectrum, would be the highest end of the spectrum, then most of their contacts should be with the community mental health staff. I think it's a good question there, Sandra, thinking about it around, primary care colleagues and Grant's here, which is great. So I could follow that up.
Thank you. Thank you. Come in, Grant.
Yeah, thanks. And thanks to Matthew, Nikki and others. I mean, I think it's a good bit of work across the system. I think that and I just wanted to note that NHS England have done sort of reviews, haven't they, locally, Nikki? And they've gone very well, very positive feedback. I think the reality is what we've tried to do is there's a lot of money in the system to care for people with serious mental illness. So we've tried to improve what we do instead of look for new. I think it is unlikely there'll be new money, particularly because the 10-year plan indicates there'll be full coverage nationally over the next decade. So that doesn't inspire me to think that it'll be in the next year that people will be investing significantly. But I suppose the real challenge, and I think that was a really good point Sandra and Nikki picked up about, particularly working with primary care, because as Nikki sort of alluded to, let's be clear, this is where the greatest discrepancy is around health inequalities in Bob, as anywhere else in England, in terms of life years, and even worse in terms of health years. So really important area, much as this comes out of a very tragic event of it's almost unthinkable what happened to those people in Nottingham, but also people with serious mental illness who on very rare occasions end up in this position, have their lives cut short, as we know, around about 15 years or more compared to, I guess, people who don't. So it's a really tricky area, but I think we've done some quite good work, and I think tried to do that within the financial envelope available to minimise risk, but importantly alongside that to minimise the health inequalities for this group in particular. So thanks to Nikki and her team and others for coordinating this work and giving us some challenge as well. So I should have said I'm Grant McDonald, mental health member for the board.
Thank you very much, Grant. Any other comments or questions? Tim and then Nick.
Thanks, Prit, and thanks, Nikki and the team for pulling this together. It's a very, very important topic. Just one detailed question, really, based on the report. It mentions, I think it's about the caseload. I think it's specifically named workers of caseload. If it's BHFT, where there's talk about an NHS suggestion of a cap of 15. And I wasn't quite sure whether it meant BHFT don't have a plan in place. So I can't confirm the current plan, or whether NHSE haven't confirmed that is the hard target. But either way, do we have any sense of when we will be approaching that 15-person caseload cap?
So it's a really good question, Tim, about whether it's current plans for NHSE. Actually, now I'm rereading it. I will go back and check that, and I will just check the timescale with BHFT because there was a feasibility being undertaken, and as a safe for staffing tool was going to be recommended. So I'll follow that up as an action.
Can I just be a bit cheeky and ask Grant, with his day-to-day hat on, as I know, rather than his partner, do you know what the position is in your world, Grant, on that, against that 15 number?
Yeah,
sorry,
so the 15. No. The 15 is a historical number from in the late 90s. There was national service frameworks published around mental health, so national descriptions of service models. And for assertive outreach teams, there was a notional capping round about 12 to 15. One of the reasons there weren't assertive outreach teams going forward was that cap was prohibitive, both in terms of finance, but also in terms of what needs to be done. So I think there's very mixed views about that being the correct model. And that's why you'll see variance between organisations. And even in BHTFT, for example, you might decide that in somewhere like Slough, having a dedicated team with low caseloads makes sense, but clearly might not in Newbury because of a density of population and relative health inequality. So there isn't a national rule. This is historical, although it's in some of the documents. I think what we've tried to do across the collaborative is think about for how do we help have different models for different people, but not just do a response as a team with a cap. Saying that, there is an intent nationally, as you will have seen potentially in the 10-year plan, to have modern national service frameworks. And I would anticipate that one of the first modern service frameworks for mental health will be around this area of assertive outreach. How prescriptive they'll be around new caseload levels, etc., is open to interpretation. So I get the point that this is written in the papers, but I think what BHFT, if they were here, would be saying, and we wouldn't, is that some areas there might be an intention for some workers to have capped caseloads so that they can concentrate on the people who need most intensive interventions, but that wouldn't be a universal model. And certainly it's not something that that in our plans we feel is something we would enact immediately, because we think there's other ways to do this, more team-based ways of managing people than capping individual workers' caseloads. But we're trying different things. That's one of the beauties of having a collaborative across different areas with different populations as well as across organisations, is we can try different models and see what works for who, when, where, so the right care in the right place, the right time sort of thing. So sorry, it's a bit complicated, and I hope that answer's reasonably clear, if not too misleading. But I think nationally, people have mixed up a lot around an assertive outreach team that was historically in the early 2000s that would have a capped caseload, and actually the function of assertively engaging people that you may not need to have a capped caseload to do if you work in a more collective way with those people, so you share the work out between others. So I hope that's clearish, but probably not the clearest answer of all time.
Thanks.
Thank you. Thank you very much, Grant.
Yeah, very quickly, I welcome the review and the spotlight it shines on the care and treatment of people with serious mental illness. Grant's highlighted the significant health inequalities that this group experience, and they die 50 to 20 years earlier than the general population, and that figure has remained stubbornly fixed for decades now. The report references Rampton Hospital, which is one of 3 high-secure hospitals in the country, which is run by Nottingham Healthcare. Our local high-secure hospital, Broadmoor, which is actually the Frimley system, is run by a trust in West London. And I suppose, again, what this report highlights is that we don't, I think, as a sector, as a NHS, spend perhaps as much time as we should talking about serious mental illness, in part because we tend to talk about mental health in its entirety. And as a consequence, I would suggest that on occasions, the care and treatment of those people who are most disturbed, most seriously unwell, can be overlooked.
I think that's a really important point for us going forward, isn't it? This is a very helpful start to being able to distinguish between those categories of need and therefore where we need to focus our attention. Thank you very much, and thank you, Nikki, again for your leadership in this. It's been really good for us to see in its entirety. Thanks very much. Thank you, Matthew. I'm going to move us then to our BCSE Alliance update. I'm delighted to welcome William Butler and Stephen Barnett, Chair and Director of our BCSE Alliance. And over to you, Hannah Iqbal, as our Chief Strategy, Digital and Transformation Officer.
Thank you, Priya. So I'll be brief and hand over to Stephen and William. So as colleagues will know, we've been working closely with the BCSE Alliance, the ICB formed in 2022. And we had a really useful session actually with Nick and Priya and William and Stephen about a month ago, where we kind of had a strategic stock take of the work to date, and this moment we're in now where we're navigating quite a lot of change and actually a lot of opportunity for working differently with the voluntary sector. If you look at the 10-year health plan, it's great to see, if you do a quick search, you can see the strength of recognition, I think, about the role of the voluntary sector currently in health, but also the opportunities to go much further, whether that's through integration, different partnerships. So I'm sure Stephen and William will that. The other point would be that as we pivot into being a strategic commissioner, there's clearly a lot of opportunity for how we work as a commissioner in the voluntary sector. So I'll hand over to Steve to present the paper, but one of the things that would be quite interesting to hear from you both on is some of the discussions you've been having nationally around the model ICB blueprint, the Alliance 42, which will obviously become the Alliance 26 maybe, in terms of how do you see ICBs changing and how are you hoping to work with the ICBs of the future?
Okay, thank you. Just a few extra questions there from Hannah, which will, I'm sure, try to address, won't you, Stephen? Thank you very much for thank you very much for inviting us. We're going to be looking at a combination of what's the current context and where we're going for the future in terms of priorities. So I'll be talking about the current context briefly, and Stephen will then sort of look at where do we go to next. So I suppose this is all about what are we now and where are we going together? And that word together, I think, is vital. You'll see from the paper just how thriving a sector we are. Just look at the numbers. Now, these numbers are 2023 numbers, and I suspect even then underestimated, particularly missing out quite a lot of small voluntary organisations. It's due to be redone this year. They've done every 2 years by Tony Chapman and the University of Durham. So you can see that we have got a lively and dynamic sector that's actually contributing a huge amount to what's going on in Bob. So our role as an alliance is very much to engage, support, inform and advocate for the sector. And structurally, in order to do that, we have a twice yearly system-wide assembly. And the next is focused on the ICB and VCSE place leadership. We have 3 action groups, excuse me. We have 3 action groups, one on mental health, learning disability and autism, and aging well. We also have a steering group, which is composed of the CEOs of local infrastructure organisations and co-chairs of our action groups. So what does that mean we actually do? Well, we try to convene the diverse sector across the Bob places and system and to channel insights and experience into ICB governance at hopefully multiple levels. We direct significant energy to health and well-being of people with disabilities, mental illness and long-term conditions. And I think we're very much material partners in the delivery of the NHS 10-year plan and the 3 shifts. And as organisations, voluntary sector organisations are very much embedded in and trusted by their local communities. And I think that's critical in terms of the plan going forward, critical in terms of how we develop our partnership. And we very much have a partnership, and it's based, I believe, on a combination of mutual support and a constructive challenge. And you'll see in the paper, we've identified what the principles are: trust, purpose, community, and inclusivity. And this all works, as far as I'm concerned, because we have positive relationships with good people, a lot of whom are around this table. So let me hand over to Stephen.
Thanks, William, and thanks, Hannah. I'll circle back to Hannah's question about national engagement in a moment, but just want to pick up a few things from the update paper. So for the next 12 months, which is a period of significant change, the 4 partnership principles remain, and there are also 4 partnership priorities which try and dovetail with what we knew already was sort of coming up in the 10-year health plan, and which are now confirmed around neighbourhood health, place partnerships and ICB governance, then evidence and community insights, and finally strategic commissioning. So just a couple of examples. On the first one, tomorrow we've got a meeting with for our Aging Well group with GP place leaders to talk about the neighbourhood health guidelines and the implications of the 10-year plan for how things might develop locally in our 3 places. And that builds on a lot of work and conversations that we had with the ICB primary care team in 2023-24 around the primary care strategy. And you've got the neighbourhood health guidelines at the end of this, and you can see that VCSE membership on the programme board is cited there. The second thing is the place partnerships, which have been really important, and Dan highlighted the work that had been done around health inequalities at place. That's been really important for VCSE NHS relationships around health inequalities. And we've actually got a Bob VCSE Health Assembly on the 29th of July, which where we're pleased to welcome the 3 ICB exec place leads for a conversation. You'll all be pleased to know that there are already 90 people registered for that event, which is a record for us at this stage of promoting the event. So that's 2 hours to sort out everything to do with the NHS and VCSE relations at place level to look forward to. The second thing to highlight is that we're working really closely with the Frimley VCSE Health Alliance as we move towards the Thames Valley ICB. In fact, I chair a Southeast VCSE Alliances meeting, so we already know each other really well, also with Hampshire and with the Surrey and Sussex leads. The third thing is that there are 2 proposals on the front cover of the board paper. One is to have a deeper board workshop discussion where we can bring in some of the people who do the real work of organising and delivering VCSE services in Bob, together with yourselves, to talk about how are we going to do this in the Thames Valley to make the most of our respective strengths and assets. And the second proposal on the cover of the paper is to feature citizen stories from community researchers who've been supported very significantly by the University of Reading and our local health watchers who've supported them to tell their stories and engage with local decision makers. Finally, we're very conscious of the period of upheaval for organisations and for the individuals who work for them at the moment. We're also not immune from those. I'm aware of several charities that are going through restructures of parts of their service, so it is a reasonably common experience. Wherever those changes take us, though, over the next few years, there will still be an NHS, there will still be a voluntary sector, and we need to have some way of talking together at different levels, both at the level of around a particular patient, but also at that big strategic level of commissioning right across Berkshire, Oxfordshire and Buckinghamshire. Together, as the paper shows, we've got massive resources, the money, the people, the estate assets between the VCSE sector and the NHS are very significant. And as William's highlighted, that unique trusted relationship with communities through specific community groups. These are not sort of parachuted in from the outside. These are groups that are formed by the community, are really significant asset, and that's quite visible in the 10-year health plan. Nationally, to Hannah's question, yes, I'm part of the Alliance 42 leadership group, and we've had an exchange of letters with the new leadership of NHS England, and there are 2 things that I think we're advocating for. One is that if the things in the 10-year health plan, which are it's sort of like a landscape painting, and you can highlight about 14 references to the voluntary sector. But if we want to do those things together, then there needs to be resource for conversations to continue to happen. And the second thing is, I think that they do talk about strategic commissioning, particularly in relation to neighbourhood health. They mention 2 specific things, which is debt advice, which I know several NHS trusts, I think including one in the Bob system, already work on. And they also talk about one other thing which escapes my mind for now, but is very much mentioned in relation to community, to neighbourhood health centres. And to do that well, you need the links, and that's what we can bring, is those strategic links with the different organisations in Buckinghamshire, Oxfordshire, Berkshire. The secret of the voluntary sector, the secret sauce, somebody said, is the number of us, the number of organisations you have, and that's what makes the trusted relationships. And just one example of that, there are 7,500 registered VCSE organisations in Bob. The one that was cited in the patient story at the beginning, Animal Antics, I hadn't heard of. There's no way that William and I can know all of these 7,500 organisations. But the joy of this job, I think, for us is that, every few weeks, every month or so, you find another charity that's doing amazing work and turning somebody's life around. And what was the quote that Jacob said? Something about helping me find who I am. And that's kind of what these organisations are really good at, that integration of lived experience and looking at the whole person. There you go. Thank you.
Any questions?
Let's open this up. I must apologise. I should have declared an interest at the start. I chair the National Infrastructure Body for sector in ICB. So I'm interested in it. Similarly.
Thank you. Since the background, non-exec director, good to see you, Stephen, and I think it's so good for you to be at the meeting, and it's good to see. I hope you agree that we will be welcoming the two items that you suggest, because actually we can't deliver going forward without the CSE. That there's no way we can deliver our system services, if you like. So recognition of the importance of you. And I just wonder, you referenced even, you know of some charities you said that were struggling with restructuring. I think most sectors are struggling with restructuring, but do you have a sense of how many are in serious distress within our patch, and whether there's anything we can do about it, or is there a sense that we'll be able to manage going forward? Can you help us with that?
I think that's a difficult question, Sim, because it's we tend to sort of hear stories, and I think that doesn't really add up to any kind of significant evidence in terms. But clearly, as Stephen says, there are a number of organisations going through a huge range of difficulty, and the one of the things that, as you know, has made a significant difference is the national insurance hike, because that's organisations who are having say contracts or grants or not getting any uplift. That's had a significant impact on a large number of organisations. Stephen, do you want to add anything to that?
Yeah, I think that's right. It's very hard to give a number. In fact, it's really not possible. There's one sort of there's one really good thing in the 10-year plan where they talk about the 3-year funding settlement from the spending review. Yes. Now, that would be one thing that we could that would really make a difference to a lot of the charities if that materializes in the real world. Okay, then if that could then be passed on in terms of security of income and of contracts for the voluntary sector where they are providers to the NHS, which is actually a small number of the 7,500, but very important where they exist and for the people they operate with, which includes people with severe mental illness. If that could be passed on with that security, that would be quite a stunning win, to be honest, because that is in my 3 years doing this kind of partnership creation job, that is a very significant barnacle dragging on the the ship of the voluntary sector and the NHS.
Thanks, Chair, and good to see you again, William and Stephen. Two questions really. One, both really related to the 10-year plan. One is there are lots of opportunities clearly in the 10-year plan, and as we've already reflected through the day, while the 10-year plan's kind of high on rhetoric, it's fairly low on detail about delivery. So my first question is, practically, how can you ensure, or what can we do to ensure that you are shaping the delivery of the 10-year plan at neighbourhood level as a sector? What can we do involved to ensure that those conversations outside of really worthwhile conversations like this at strategic level, but day by day, how do you get into that conversation? How do voluntary and community sector organisations who frankly have often found it difficult to get into operational conversations? What do we need to clear out the way to ensure that you do that? That's question one. Question two is, having worked for a few national charities myself, one of the observations I make is that there's a really subtle but quite dangerous process that can happen of creating a dependency through commissioning that takes very gently but perniciously takes away the identity of the charity, because what it does is it creates a framework by which the charity's got to operate in order to be commissioned, in order to fulfil the objectives of the commissioner. And if you're not careful over a period of time, the identity of the charity starts to transfer into just being a service provider, as opposed to the charitable objectives that they were originally, defined for. And the danger of that is it takes away innovation, it takes away the kind of the connection that the charity has with the people that it's there to serve in the first place. It's a bit about, paying the piper and calling the tune, I guess. How do we avoid that? How do we ensure that you don't get sucked into, with all these opportunities and all the good stuff, and potentially 3-year funding windows, which are all really important for sustainability, but how do you, protect the character and the soul of the individual charities in that process? Not easy questions, I know, but I'd be interested to get your opinion.
No, they're certainly not easy questions. Let's try and sort of tackle them briefly. The first one, I think, about obstacles, for me, the starting point is sort of recognizing that there's a significant power differential between, the NHS and VHCSE organisations. And if we're generally going to be partners, we have to recognise that imbalance and try to do something to shift it. And that means, if we're genuine partners, it means people being in the room, and therefore there's quite a lot of variation across the different places involved as to, whether or not representatives of key service delivery organisations, for example, are actually in the room and feel as if they're genuine partners. Now, I think there's been discussions about how that can be addressed, and we've already touched on perhaps how that can be addressed in the 10-year plan going forward. But for me, there are significant obstacles around that. The second question is a perennial one. It's the whole kind of thing, and I've run large service delivery voluntary organisations, both mental health and substance use. And inevitably you get into the kind of situation where you can very easily feel that all you're doing is serving what the contract is saying, and there is a danger, right, in that kind of situation of losing your own kind of identity. So how do we guard against that? I think we guard against that by continuing to speak out and not to always think that just because we were being the paymaster saying X, therefore we always have to do X and more than X. I think we have to constantly look at how, as voluntary sector organisations, as charities, do we continue to do that traditional innovation on which an awful lot of other innovation is then based on and grows from. Stephen, do you want to add to that?
Yeah, I think it's so it's for each individual charity or social enterprise to manage that risk and that opportunity. And I think some of them will feel that over a period of several decades, they are probably shaping services that they are then commissioned to provide, and that's a sort of longer term story about philanthropy in the public sector. But it's important to remember that it's also a story of the whole sector. So some of the charities will get closer to the NHS, the national, to the local authorities, to the national government, to DWP in terms of commissioning and procurement, but some of them will not. And those that are closer will also want to manage their degree of risk on different income streams. And they will often mix contracts from the public sector with income from grants and foundations, which has got a lot harder, especially for very small local organisations, with the power of volunteers, with public fundraising from various different sources. So I think it's actually a really interesting thing from a public sector, from a government point of view, that if you put money into a charity through a contract, it will, and it's secure for a number of years, the charity will probably go and innovate using other sources. And that's a really healthy sign of a good, vibrant charity that's well governed by very committed trustees, which some of you may be.
Thank you. I'm going to bring in Heidi and Nick, and then we'll have both, and then we'll come back.
Thank you. Thank you both. More of a reflection really than a question. Firstly, thank you for commenting on animal antics. I think the power of Jacob's story really did demonstrate, as we've already said, system working and the impact of charity organisations. And I've been reflecting on the 10-year plan and the comments we've said earlier around the concerns we have around Health Watch potentially. And I'm looking for perhaps an action for us to take away as a board to work together to better understand how, with our BCSE partners, we can reach the people in our population. And I'm looking over to Sarah, not sort of speaking for you, Sarah, but thinking about our public involvement, our patient insights, our patient experience, and also our users, our experts by lived experience. And I think there's some real opportunities there. So I welcome doing that in the future as part of our delivering the 10-year plan.
Yes, Stephen, William, good to see you. Thank you for your presentation report. Just very quickly for me, what do you see as the benefits of the Alliance and indeed the sector as a whole of the move to a Thames Valley system?
Oh, Stephen, do you want to kick off on that one?
Yes, thank you, Nick and William. So a lot of the Berkshire charities are used to operating on a county footprint. So I've got quite a number of members who are very active in both the Bob VCSE Alliance and the Frimley Alliance. Now they're happy to do it, but I think there is some frustration about having to do that kind of advocacy twice. So that is a potential advantage to doing it this way, and we already have very good connections with those. There's probably more work to do for us around the connections with the very local ones that only operate in the east of Berkshire, but that's work we can do, and we can build on the work that the Frimley VCSE Alliance has already done. I think I'm being a bit riskier here, but I think also the move towards devolution and Thames Valley Mayor and having that connection is also something that would be very interesting for the VCSE sector to have over time.
Yeah, I mean, the only thing I could add is, I mean, it's going to be obviously the classic interesting journey. And, it logically, it seems to make a lot of sense. But like all change that we all have to manage, it's about the transition and the challenges that we're all going to face, particularly you and other executives, Nick, in making this work.
Thanks, William.
Thank you both very much, William and Stephen. It's been very good to have this conversation now. It's the first of 3 parts this afternoon, really focusing on community. So we're going to come to our place discussion next and then our neighbourhood discussion. William and Stephen, if you're able to stay with us, that would be great. And we might just come back to you so that the conversation is broadened out as we go through these next pieces as well. I think it would be helpful to see if that might help our discussion. There were 2 proposals in the paper, one about really using a workshop format to try to understand how we would work together well from a 10-year plan perspective, and the other is to have the equivalent of a patient story to really demonstrate. I'm hearing, feeling, picking up support for those as concepts. And I think as we work through this next period of how we're going to engage in the actual plan that comes from the 10-year plan, I think that's going to be really important and helpful. So thank you both very much. Let's hold that there. I'm going to move to Dan Levison now, and then we'll be to Ben for our neighbourhood session as well.
Thank you very much. So I won't present slide by slide. I'll just give a little summary, and then we can have a discussion on Dan Levison, Director for Places and Communities. I'm presenting this item on behalf of the Buckinghamshire Executive Partnership, and so a lot of the concept was developed by the Associate Director Euston, and I'll invite George to add anything at the end as well. Executive Partnership. A couple of things that I want to highlight is, so as you can see from the slides, Buckinghamshire's made really significant progress as a system in delivering some of the neighbourhood working that has been a real feature of the recently published 10-year plan. They've organised the county into 6 integrated neighbourhood teams that composes between 1 and 3 primary care networks. They're probably up to 90,000 to 150,000 population. That's not to say that's the single team. It's probably more reflects a network of teams and multidisciplinary teams that work within it. I think it's important as well to recognise that these are teams from across the system. So to Stephen and William's point, the voluntary community sector is very much involved, as are local authorities, GPs and NHS providers. The system has managed over the course of the last 12 months to do a really good bit of system planning using, as I said earlier, the Better Care Fund, the Urgent Emergency Care Funds, Health Inequalities Funding. So funding where there is a little bit more discretion for places to make choices about how they use it, to agree the priorities and then plan accordingly. So that's been really helpful. And again, that funding has enabled us to leverage other funding from other sources, including the NHS providers, the voluntary sector. The areas that have been prioritised as part of that planning are the areas of deprivation, particularly. So the opportunity bucks areas have been identified as areas for particular focus, particularly given some of the stuff that we know anyway, but the healthy livelihood of people living in those areas, experiencing the inequalities. And then finally, and I think really importantly for the system, there was a county-wide launch. Now, George, I think it was in 5 of the 6 integrated neighbourhoods. There was a coordinated launch event as a system where we took, led by public health, actually doing a lot of the data-led, the insight, using the connected care data alongside public health data to really understand the community needs. So, harking back to our role as strategic commissioners, using data and evidence to inform what we're going to do next. So that was a really important thing. And then finally, I'll draw attention to a couple of things. Bucks has managed over the course of the last 12 to 18 months to agree a single health and wellbeing strategy for Buckinghamshire, which again fits into our overall integrated care system strategy and national strategy. And I think that's quite important. And again, it's something that we've done across the 3 places, really committed to a single direction of travel as a health and care system, which helps and sets out outcomes that we're going to achieve. And then you'll see from some of the slides, the work with the voluntary community sector is really fundamental as part of this work. So things like I mentioned earlier, the community health and wellbeing work is delivered and part of the 10-year plan is likely to be, I think it was one of the case studies of the 10-year plan. These people going door to door to support proactive care, identifying a lot of the unmet need, particularly in the most deprived streets in the most deprived areas. So that was really important. And again, some of the stuff that, as Stephen and William said earlier, some of the things that the voluntary community sector can do around our cultural systems, our ability to build trust, our ability to understand community assets, stuff that we traditionally haven't necessarily been great at. That is this community-based, strength-based, asset-based approach. We are learning how to do it. So connecting in with the stuff that is in communities and the strength that communities have is really important, and the voluntary community sector really helps us to do that. And then I suppose I'll finish, and George, please do add anything that you feel I've missed. But I think the work and the presentation and the content within it does demonstrate the power and potential and the impact of place-based partnerships, particularly those systems working together. And it is really a reflection of this that's made it happen. So it's really great to see. George, I don't know if you have anything to add.
Thanks. So I'm George Gabriel, for Prime Medical Services. So my conflict of interest here is I'm the director of GP Provider Alliance, and I sit in that partnership, the chief execs of the mental health, acute community and local authority. I think this is kind of really it's the end and the start. So it's the end of several years of relationship building, of kind of strategic planning that has been based on a knowledge that we're moving towards this neighbourhood healthcare delivery model, and obviously working towards a 10-year plan. We're kind of in that strong position now to really kind of get going. Pilots are done. We're actually kind of getting to doing work. I think the big credit here actually goes to the Bucks Partnership delivery team. So essentially, as chief executive, you know, sit on a partnership board and you know, obviously challenging for assurance, but all our organisations have provided members of the delivery group, including BCSE, people like Bucks Social Care Academy, and they've done a really difficult work. And by the difficult work, I think the most important thing is the difficult work. So the thing that I'm really pleased with is that we go into this position now where we have a 10-year plan, where we have the ICB blueprint, and we have nailed down the geography. We have, you know, which has been tough. I mean, not unpleasant, but we have in place plans for the leadership of these neighbourhoods, which is funded through, you know, joint commissioning funds, which is supported by everyone. I know that the appointment process, the interviews have happened. We're at sort of offer stage. We've got directors for integration in post, co-directors, with one coming from a primary care background, one coming from an acute trust background. So it's a really genuine collaborative piece of work. It feels like a kind of true partnership of equals. And it's now that kind of really exciting bit where I think once we get the integration leads in place in each of these 6 neighbourhoods, which, you know, we're really now looking at people's notice period and then really getting going, I think it becomes a genuine impact on people's lives, which is actually the key part.
So can I open up to comments and questions, and then we'll come to Ben, and I think we'll have conversations around then as well. So Sandra.
To the Green Troop and Community Health and Wellbeing Workers pilots, is this the only area we have? Do we have it in any of our other areas or is
Yeah, so we've had a pilot of community health and wellbeing workers in Barton, so not far from here in Oxfordshire, but the last 18 months they were from the health and policies funding, and Didcot, I think, as well chose using their ours funding, their extended roles funding to do it. So we've got a couple of pilots starting, like with all of this stuff. The prioritisation is the challenge. We're building. I think what's good about taking this approach is we build the evidence as we go and then expand.
And that's what I'm so sorry, but just follow up. I absolutely understand that there's something about how do we, the Bob system, really demonstrate evidence and what works well and where we need to spread it. I do think it's a challenge that we can quite answer for you. You know, there's 1,000 flowers blooming, which is absolutely the right thing to do in test and pilot, but once we know something's working well, how do we spread it?
Yeah, and I think that'll be part of the strategic commissioning stuff that we get into is exactly that. It's how we make choices about evidence-based interventions that are going to deliver what is in the
It's such an important point. Come to George and then
Just to kind of come back on that a little bit, so it's a bit of an overlap with the next item, and obviously next item talks about, you know, neighbourhood delivery and programme awards. Yeah, I think there obviously bits in there around the function, and one of the things I'm going to bring up, I think actually the sharing good practice part of that, I think, is the key. But, you know, I'm very much minded, I would be obviously, to kind of, you know, let the neighbour lead, but that board should be about making sure that the good stuff that happens, whether it's organisation or infrastructure or priorities or programmes, is shared and copied rather than recreated.
and sitting back going on effect like that, and in a way George has picked up, I would go and say, because I think the best examples of this work really takes it's community led, isn't it? But it's the most difficult pathway to take. It takes a long time. Relationships need to be built, but it's the one that we need to stick with. I think to point out that I'm really delighted, George, to hear you use the word exciting, you know, because this is that part, and I think Buckinghamshire have shown, you know, our other places too, how this can be done through partnership. And we've been talking a lot about this, and we're in a good position, really, to start scaling aside of the sector. So I think we should be very thankful and joyful, and just take this as an idea of how it can be. But we need to scale that. Such good news.
Yeah, just very quickly for me, and I hadn't appreciated until I saw the map, but geography behind looking at INC looks a little strange. Clearly there's a compelling rationale behind it. It looks like there's 3 separate bits to it.
Yes, so can I answer that? So there's kind of 2 reasons to it. So the first is around the geographical alignment, and I mean, this is a really hot topic nationally. So the decision in Bucks, which was heavily debated, that the geographical alignment around primary care networks, patients choose their GP. That's, you know, the registered is the key here, and so that's where it's kind of been debated in other areas. So in Northwest Temple, borough areas, and you know, so it is so that's one part of it. But the second is that if you look at the areas of the map, actually the demographics of what look like outlier areas are very, very in line with that of Wickham, which is obviously the central one. Whereas if you look at you know, the areas on the map, I probably don't get the town specifically, but you know, you could say, well, why is it not within our actually demographic? Not it is straight which is more Wickham than Marlow. Yeah, very helpful. That depends.
That's an important point for us, isn't it? Because actually that is purposeful decision making about what you put together, and that I think is really good. Dan?
It is, but I do think as we go through this process, it'll iterate. I do think some of this isn't set in stone, and I think we'll actually change it more for you.
Good. I'm going to, Keith, and then Tim, and then we'll come to.
I got picked out of teams, so I might not be picked up. But I just wanted to ask, with Slough being at the bottom, the move with Frimley, might some of the areas evolve where there's areas of deprivation and there's benefits of co-working across areas?
Yeah, I mean, I think geography is really interesting. So at the moment, the kind of neighbourhood strategies are being developed at place level across our 3 places. See that will change, particularly in the Berkshire area. You know, one of the challenges we've had is from our team-based practices and services, which say, well, actually, we look a lot more across into Oxfordshire. Should we be looking at neighbourhoods in Oxfordshire? To be honest, I think really it's just too difficult right now to try and have a cross-place neighbourhood. I think it's something that Dan, you know, alluded to. These are the starting point for Bucks. It may need to sort of develop, and Slough certainly be sort of part of conversation. If you look at our south of Bucks area, most of them they're looking to split them up, and they don't really look into PhD. So you know, those are the questions that we will develop.
And I think that's a really important point. What we're trying to do here is take that population approach, so we know where people access their services, where they do their shopping. These are the important things, as opposed to the boundaries we draw on maps of the organisation we take. So I'm sure there'll be some opportunities to extend.
See what happens with the local authority plans. I think that's they're going to be really important.
Yeah, I mean, this is just the exact opposite of this morning's conversation in terms of positivity. And I think you've made a really important point this morning, Priya. You talked about motivation in your wrap up. This is, you see in Sim's reaction as an example, this is why we all got involved, Elizabeth. It's not our job, because we want to see more of this stuff. And you know, you look at Tony's story, Sophie's story, they are absolute real people who we're doing the right thing. And I mean, get super enthused about it, which is brilliant. Their frustration is, well, how do we do more of it? How do we do it more quickly? And speaking to George over lunch and so on, talking about this section, you know, it is about the relationships. We know that, you know, it's Neil and Raghu's attitude in particular, and not just them, but because they get 70% of the budget for Buckinghamshire healthcare, because they're the acute trust, it's their willingness to let go, to be progressive, be open, that is allowing more of this to happen, because Dan and George and them banging their head against the wall. It's how do we turbocharge this and use a strategic commission? Because, you know, George is saying, well, the money's never going to, there's not going to be more money. No, there's not. But we're the people, we control the purse strings, the people around this table, or particularly the execs. So how do we? Obviously, it's brilliant if the horse is already being led to water. it's already walking for, so we don't have to leave it too much. But where we do, how do we actually do that and not see it as negative? Because it's not about stopping people have money or stopping people have resource. It's helping Tony and Sophie. This is the real world. When we do it right, this is what happens. So
I think Dan,
super positive.
Yeah.
keen.
Yes, and I think one of the answers is don't constrain it. Like Sim said, this as much as anything, what we're talking about is a cultural program, and we'll be asking not just leaders to take risks that we've not taken before, but we'll be asking teams that work with those people to manage risk in a totally different way. And I think we have to do a lot of cultural work, and we have to turbocharge. I'd love to turbocharge it, and some of it is probably around the prioritisation. So prioritising right now the people that we know will benefit right now from this, and do some. So we know there's people that are going to the hospital that shouldn't be going to hospital, and we can do things differently. But we can identify with the data. So that's one thing, the cultural bit, and then the other bit is I think we need to be cautious not to stifle it with over restrictive governance and structures and things like that. I think that George and I were talking before, there will be a temptation to leap to what is the organisational form, integrated health organisation, what is the contractual mechanism. To be honest with you, a lot of what we're talking about is, and I think Grant said it, we've got the resources that we have out and about, we've got community assets that we probably underutilise, and communities themselves that we underutilise. So let's organise that stuff, and then the organisational form and the contracting, things like that will follow. I think when I've seen these things work, that's when they work. I think when I've seen them fail, we probably tie ourselves enough to kind of structure it, organise it, contract it.
It's really helpful conversation, because that is where we're focusing, isn't it, in terms of understanding what it's going to mean to be able to be the next iteration of us as an ICB. And part of that, so what's our job around a board table? It is to hold ambiguity, and it is to manage risk, because risk is going to transfer, it's going to change. That would be the big thing that we will see. At the same time as what are our leading indicators, leading edge indicators of quality, of safety, of good performance, etc. So we've got very sound building blocks for this, which is good to see. So over now to Ben, and then we'll come back into this conversation.
Thanks very much. Yes, so at the last board, we had a lively and engaging discussion about the importance of leadership health, and had another one today, I think, already, and it's continued. And as colleagues have highlighted, it's very much founded on that principle that occupiers are creating and maintaining the papers. That is where we can do very useful work. And this is the end point. We've also reflected on how, in all the places we've got our system, we have seen some great examples of innovation. Colleagues have been working on maybe with Help Us On Time, delivering the primary care strategy that the ICB launched last year, and using that as a springboard. You see the teams already bringing services closer to people, redesigning care, and building those effective partnerships. Last two items really at home, really. But we do also know, as well as all of that, that at an ICS level, our patients, our local authority colleagues, and our population health data are telling us that these successes are too valuable to allow them to remain in isolated pockets. And we need more consistency, scale, and we need to develop a clearer shared vision for neighbourhood health, and we need to apply that to all our citizens and make it very clear. So it's too good to keep limited to these little areas and pockets consistently. So that, in a nutshell, is the purpose of the neighbourhood health programme that we're proposing here. So in the proposal, we've set up 4 shared outcomes for our citizens that every neighbourhood in our system should be working towards to deliver the ambitions that are set out in the 10-year plan. And these 4 are locally tailored health improvement and illness prevention. That will include the outreach to communities, practically, as we've heard some examples of this now. The accessible coordinated care for people living with common long-term conditions such as diabetes or heart disease. And the 10-year plan sets out some very ambitious goals there around, making our patients as I think in the past for some of these conditions. Why should people have to go to hospital? actually coming to their neighbourhood. And the third one is the person-centred care close to home for people with complex needs, frailty, or who are nearing the end of life. And then the fourth sort of ties it all together really, that's developing those sustainable community resources, workforce, the capabilities that enable these to be provided in every neighbourhood and to be sustained, and to make those communities themselves resilient when it comes to maintaining health. And this definitely isn't about imposing a one-size-fits-all. It's about having a system-wide framework for improving equity and consistency. And absolutely, must have space for local flexibility and innovation within that. And that will be absolutely reliant on the successful partnerships we've seen in action this afternoon across the local BCSE and community broadly. So to deliver this, the programme has two key parts working in harmony, which is the place-led design and delivery, just illustrated now, shaped around local population need. And that's system-level support nation, providing the tools and the frameworks and the supporting states and workforce development infrastructure behind that. All the partners, including the ICB colleagues, have been very clear that the programme won't succeed through a top-down prescription. So it's absolutely not it's the teams and those local organisations that enable us that and deliver with care. And the role of this wider system, this programme, will be to ensure that the support for those teams is aligned, strategically commissioned, financially, and that the population health and experience data is appropriately analysed, organised and shared, and the impacts of this new way of working are measured and evaluated so that we can learn from that and apply appropriately. And then the programme award with its terms of reference as described in the proposal will play a key role in taking that coordinated approach happen. That's still for that system level leadership, governance, and this space for collaboration at a system level, but not just like place this the prevalent of that as well. And also to provide a focal point for championing co-production, embedding that prevention approach, and ensuring that we do share that learning as we go along. So just to summarise, we know that there are great solutions already adopted. This programme is aiming to make the very consistent systems regardless of what risk that's the summary.
Thank you very much, Ben. So I'm going to invite Dan and then William and Stephen to make any comments or share any thoughts first, and then I'm going to open it up to the board for comment.
Yeah, I didn't really have much to add. I think, like Ben says, we tried to find a way of working this out as the ICB and places, because I think, like Ben said, there's no point in trying to force something on that. I think there's some things that we as an ICB can do that can really enable places to be successful. That'll be the success of this programme and the success for the residents. So things around population health, well, the first thing that Ben said, setting that clear vision strategy for neighbourhoods. Some of the stuff, Chair, around agreeing some of the outcomes that we're driving for is really, really helpful rather than being too prescriptive. Set that direction for us that can help. So it's identifying those bits and then freeing up places to be the engine room, which is described in the Health and Care Act.
It's so helpful for us to focus, isn't it? Equitable outcomes. That's what we're really striving for. How will really depend on the neighbourhood. And that's so important. William, Stephen, don't feel obliged, but if you would like to contribute, please do.
Yes, thank you, Chair. William, maybe come in after me as well. I just want to say that I absolutely recognise the story that George and Dan have told about Buckinghamshire and that sort of local partnership working. That's also what I'm hearing increasingly from the BCSE sector side. That is a strong evolution. I think the other thing I'd say is we've talked about the VCSE sector, but we were also trying to highlight the different kinds of organisations that exist within that sector. And it'll be interesting for us to think about how we try and relate to both kinds. So there are charities that are specialists in long-term conditions, that will be able to work on a sort of quasi-medical way, that will understand the medical language because they're patient organisations as well as service providers. And there are others that are really about the social determinants of health and about health inequalities, and they're typically smaller, and they're hyper local. I mean, they're much more local than the neighbourhood base of 90,000 people. So I think the conversation that we still need to have for Buckinghamshire as for the other areas is working with, just to simplify a little bit, those two different kinds of VCSE organisations. Now that we're recognising that VCSE is a key part of those future integrated neighbourhood teams, healthy neighbourhood centres. William.
No, I've nothing to add. I'm fine. Happy with that.
It's really helpful. I think there are a number of inputs that if we consider them well at the start, we give ourselves the opportunity to achieve a lot in a shorter time. So that is helpful. And anything, I'd open it up now to board finds questions.
Yeah, just a quick one, sort of building on what Ben's just been through and the previous presentation from Dan. Again, it's just so positive, and it's great that we've got the vision and know where we want to go. But just if I just look at slide 3, which is the NHSE requirements, those bullets are just, I mean, you can't disagree with any of them. They're obviously supremely, laudable and aspirational. But my question, I suppose, is what's stopping us now from doing more of this more quickly? What are the barriers? You don't have to answer this now, Ben, or anyone else, but I think isn't that our job, is to try and, with the exec leading, obviously, identify those barriers, and then work collectively to try and remove them or reduce them. Some of it is relationship, as Dan said, and that will probably be the biggest part of it all. Ultimately, that oils the wheels of everything. But is it regulation? Is it targets? Is it money? Is it estates? What? I mean, it'll be different in different areas as well. But that's the point. We need to get granular and specific. Not the board, but to say in this area it's that we haven't got. It's a building is the main issue, and people. In this area, we don't have any relationship with the local authority. It'll be different, and it's how do we turbocharge that and give the team the resources and capabilities to do it, because this isn't new, is it? I mean, there's nothing on that slide is amazing revelation. It's been like that probably for 10 years, and it's not just Bob, but we haven't done enough of it. So why not? What are the blockers? That's why I don't expect an answer.
So Nikki's keen to come.
Oh,
No, but I think just on the blockers, isn't that the real opportunity this time to be able to say, actually, if we are going to work at neighbourhood is really hyper local. If we get it right, and that is where we will get the real intelligence about where locally that money. That doesn't mean we can put the money immediately in all of those places, but it gives us an opportunity to understand what would lead to equitable outcomes, and that is really Dan would like to.
Yeah, just to add to it, I think it is a little bit of all of it, but I think the important thing to say, Tim, I think everything in us, we have everything. I have a really, really dull deck of slides that I've shared with Matthew about all the governance, the legal frameworks, the contracting mechanisms. Everything is there for us to be able to do it, Tim. It's just we really haven't built that momentum behind it. We've been driving for different types of things in the past. We've been competing. I do complain whenever I get an opportunity, when people come and visit us, I do complain about regulation. We are so determined to regulate as organisations, and some of this stuff is system-wide. Some of our performance, some of our quality is system-wide. We've got to get better at holding systems accountable for that stuff. But everything, I don't think there's anything new within the 10-year plan. I'm probably going to be utterly wrong here, but that makes it easier than what we already have. We've got agreements. We've run our business for years. So why are we not doing more?
I'm gonna hold us now because I want Nick, Sim, and then Sandra the last word.
So I really welcome this, and it builds very nicely on the conversations we've had all afternoon. Obviously, it's a great response to the 10-year plan that sets out our vision in relation to the opportunities that neighbourhood health brings. A minor point, I think it's an important one in relation to language, how we will engage people. So, the 4 consistent outcomes. Now, I read those as being communicated to the programme. When I hear the word outcome, I tend to think of all that will mean for individual patients. And if I was a patient with a long-term condition living in Wycombe, read this, I think, well, what does that mean for my care? So just reiterate and think about how,
Yes, and thank you picked up on what I want to say on slightly different angle. So if you look at, is it slide 5 of 14? People of Buckinghamshire have told us, and there are 3 bullet points. They want more coordinated enjoyment care, they want more focus on prevention, they want more to that. That to me is the outcomes that we need to measure ourselves against. And really, the people of Buckinghamshire wants to speak with the people of Oxfordshire and the other counties as well. It's that clear, it's that simple in what is required. And if we can maintain our focus on that and talk about outcomes, just as Nick said, which relates to individuals, this makes all of this much more meaningful to our public. So I think that for me is what I'll be holding on to. The second thing that really struck me listening to all of you is this culture piece. It's all about a different way of working, isn't it? And it's all about, I think, agility. We've talked about that before. That's not the usual course for an NHS provider or an NHS institution, but it's something we need to adopt in order to be able to scale up. And the second thing is, I suppose, well, I suppose it's sort of the risk management, isn't it? Because with that agility comes the sort of having to let go. And again, that's not something the NHS is used to, but it's going to have to adopt. We'll have to adopt that risk and help parts of risk in order to succeed to get back to a more coordinated enjoyment. And what tends to happen when I get documents like this, I'll tend to word search to see where the culture and organisational development is getting it absolutely throughout the system. So that's hugely important. And yet it's not in the NHS requirements, it's not talked about. So it's something you recognise how important it is to change doesn't happen through a nice document, it happens through people doing things differently. So it's just about how we factor in genuine facilitation of that to make sure that happens. Because it doesn't just happen. It can do if you're lucky, if you get the right team and the right leader, but it does need interventions.
Good, purposeful, really focused, excellent.
I just find the membership of the programme rules.
Yes, so we didn't specify, we just put some general delivery about that it will include health related quality PCSE, patient access and other statements, but we didn't go into the detail of that. But yeah, they could put on a list and circulate that. The next step if people are happy with the whole question of travel.
Just again, our experience of these things is we have to manage this membership because there is an unlimited demand for people to become these things. So we just have to manage the memberships really carefully so that it remains perfect.
I mean, so I would urge that if we've done this, it's super lean, this because actually, you know, if you look at how we are in parts, we've got direct integration, co-directed integration. They can bring the perspectives of all of the components, you know, be that primary care, be that BCSE, into that programme board, and that, you know, that allows us to then make it a sharing good practice and a green assurance. You know, I think it's really important to have people like primary care and BCSE in the conversation. It's really important to have a conversation at the neighbourhood levels, at the top board levels. Yes. And then the appropriate execs, and then just keep it lean and keep it about how do we do good stuff and make sure that it's being cascaded. So that would be my.
One thing that came up when George told me at lunchtime, he said it's actually the level below the delivery people that is the key group. It's not actually the board, they just do I don't think you said this, but effectively rubber stamping and approving. The doing is a level below.
Yes, so shall we bank that then? That it's a very important, which plays to both our agility and our culture, that we are not creating a culture where a voice can only be heard if it is physically in the room. Yeah? So we know that we need to set strategic direction through this board structure. And in order for that board to be really clear about the strategic direction, it's going to need to be confident that it has all of those voices. And those voices are best, loudest at neighbourhood. And therefore we will aggregate that into the board structure. I think that's a really helpful way of looking at it. Thank you to Dan and to George for the real clarity of why that is needed. It's really good. I'm going to take us through that. I'm very grateful to Stephen and William for joining us this afternoon. Real thank you also to Dan's colleague Nicola Newston for her extensive work on the Buckinghamshire paper, and to Ben and to all those involved in the neighbourhood conversation. This is our first board conversation around really bringing together the elements of that 10-year plan. So I'm going to move us now to our assurance in year, and that is to receive the reports from the Audit and Risk and System Productivity Committees, which have met since we last met, and invite Sakib Ali and Tim Nolan to highlight anything not in the report or from the report. So Sakib, over to you.
Thank you. As has been mentioned earlier, the accounts were submitted and the annual head of internal audit opinion was significant assurance. External audit was a clear audit, both value for money segments, and the anti-crime report counter fraud came back with a green on counter fraud functional standard. So I think, as has already been said by a number of people this afternoon, I'd like to thank the finance teams and everybody that was involved in getting across the line and on to another year. So thank you.
Over to you, Tim.
Yeah, I mean, not a huge amount to add to the report. It's quite short and self-explanatory, I think. The risk reporting has got better, and obviously it's got a lot more. It's going to get a lot more challenging in the coming year and months and years. We discussed a number of times at this meeting, but the dashboard we receive now is much more usable, and so thanks to Lynn Casey Sturt. Sorry, I hope I got that anyway. Lynn, anyway, he's done a good bit of work there, and Alistair's team contributed well to that as well. Finance, well, we talked about it already. The SIP position in particular needs a lot of focus, as does the cash position. But Alistair and the team are, I think, on top of that, got a firm grip. Operational, we talked about cancer again today. One thing to flag there is, with the absence of the PHPE committee, it's with a little bit of concern on where it's going to be picked up. And I know Hannah said there's a review imminent on that. So just to flag, there's a danger, hopefully not for long, that it might fall between the slats. So hopefully that will get picked up. DDAT, we're still the committee that the digital team report into. So Andy comes to us and gives us a good update on that. It's generally moving quite well. Obviously, things are somewhat in abeyance while we go through a transition. The CSU impact on that as well as an area we have to keep a close eye on. But generally, yeah, the team seems to be doing some good work on that, and the day-to-day dashboard from operational side from primary care is generally pretty good. There's an occasional minor issue, but nothing really burning red. So quite good.
Thank you. Any comments, questions from the board on this report or any other in the issues? Thank you, everybody. That's been a really helpful meeting, and I will ask then, just around the board table, any other business? Around the table. Oh, thank you. So I'm going to close our meeting, and our next meeting in public is on the 9th of September at 1:30, and we'll be circulating details of how to join. Thank you, everybody. Okay.
Thank you.